that in a question answer format. We'll be discussing, you'll be asking questions in case you have, and we'll be discussing. So these few questions are on bronchiectasis as a broad topic. So bronchiectasis, we know when the airways they basically dilate, they dilate beyond their capacity and they become ectatic. Hence bronchiectasis. Now bronchiectasis, the problem is that the patients they keep on producing secretions which cannot be coughed out because they are not in the viable part of the airway. Hence, they retain secretions. And when the secretions are retained, they become infected with time and then they produce symptoms. So typically the history of patient is that they have had long history of pulmonary infections and they've been cupping copious amounts of phlegm every day, which gets infected off and on. So we have a scenario here where we have a 35-year-old male presenting to the pulmonology clinic with complaints of chronic cough, dyspnea on exertion. He is just 35. Recurrent respiratory infections over the past several years. He reports a history of childhood asthma but denies any significant smoking history. Physical examination reveals digital clubbing and coarse crackles on auscultation of the lungs. Which of the following is not a common etiology of bronchiectasis in this patient? Can anyone tell me what digital clubbing signifies to us?
There's uh, decrease in tissue oxygenation,
So, yes, the classical answer is it signifies chronic hypoxia.
hypoxia.
Yeah. So, whenever chronic hypoxia is there, the capillaries on the nail beds they become uh, they they clump up together, and then that is how clubbing occurs. So now the question is, which of the following is not a common etiology of bronchiectasis in this patient? So he's just 35. So cystic fibrosis, COPD, asthma, tuberculosis, congenital bronchial atresia. Anyone who can opt for the answer? Yes, it's a simple one. So it is just based on the etiology of bronchiectasis. So let's see that this is basically a patient who has symptoms and signs suggestive of bronchiectasis, chronic cough, dyspnea, respiratory infections, digital clubbing, and coarse crackles. Now, asthma, we all know that it is a hyperreactive airway, and it is in response to some allergens. So, asthma can predispose individuals to bronchiectasis due to chronic inflammation, but it is not a direct cause of bronchiectasis. Everything else, cystic fibrosis, we understand, COPD, we understand. Asthma by per se cannot lead to production of bronchiectasis. Tuberculosis again can do the same. Congenital bronchial atresia also can do the same. So this is basically how we rule out etiologies. These are as basic questions as possible that come in an MRCP, and then these are very simple, but then we tend to not do them, and hence we lose marks there because sometimes we are not paying attention. Now, the next question is a 45-year-old female patient presenting to the Respi clinic with a long-standing history of chronic cough productive of copious purulent sputum, intermittent hemoptysis, recurrent respiratory infections. Till this statement ends, you should already have made a diagnosis that this patient is suffering from bronchiectasis. This is classical history of bronchiectasis. Long-standing chronic cough, productive of copious purulent sputum, intermittent hemoptysis. Why hemoptysis happens in bronchiectasis? Because of the ectatic airways, where the capillaries they open up into the damaged alveoli, and hence leading to blood-rich phlegm, that is hemopsis. And she reports no significant past medical history except for childhood diagnosis of asthma being well controlled, inhaled corticosteroids. On examination, she appears chronically ill with digital clubbing noted on her fingers. Auscultation reveals coarse crackles over both lung fields. Chest X-ray shows bilateral opacities with the ring-shaped appearance. Given the clinical suspicion of bronchiectasis, which is the diagnostic test most appropriate to confirm the diagnosis? Anyone?
HRCT chest.
Wonderful. So it is again a very basic question that HRCT chest is the investigation of choice for bronchiectasis. Although rest of them will also be done, like PFT will also be done to check the pulmonary reserve, bronchoscopy and BAL may be required. If the patient's phlegm is not able to help us with any cultures, chest ultrasound will not add anything. Same is true for MRI. So out of PFT, HRCT, chest, and ball, the test that is diagnostic of bronchiectasis as the causative or the disease process that is leading to all the symptoms, the answer is HRCT, chest. Okay. So the chest X-ray findings of ring-shaped appearance and are suggestive of bronchiectasis itself, while other diagnostic modalities may provide additional information, but the diagnosis of bronchiectasis will be made by HRCT chest. Similar question, patient has a complaint of chronic cough. He is young, he's just 30, he has nasal congestion, recurrent episodes of sinusitis. Over the past several weeks, he reports history of infertility. Does this history ring any bells? What kind of diagnosis we are dealing with here?
Cystic fibrosis type of things.
Yeah. So we club them in ciliary dyskinesia. So ciliary dyskinesia are a group of disorders in which there is dysfunction of the cilia of the airways. This could be immotile cilia syndrome. This could be Cartagena syndrome. This could be cystic fibrosis. This could be yellow nail syndrome and so on and so forth. So the thing is that the crux of the story is unable to get rid of the secretions. Physical examination again reveals bilateral nasal polyps and digital clumping. Chest auscultation has coarse crackles predominantly over upper lung fields. Chest X-ray shows bilateral upper lung opacities. Now, this is an interesting question. So here we are, upper lobe bronchiectasis, bilateral. Which type of bronchiectasis is most likely to be associated with this person's condition? Cylindrical, varicose, cystic bronchiectasis, secular, or central bronchiectasis? This is a good question. Okay, what are the positives in the history that are guiding us? One is that this patient looks to be ciliary dyskinesia. Second, there are upper lobe consolidations. Usually in Cartagena syndrome or these immotile ciliary dyskinesia, usually the bronchiectasis is in the lower lobes because the more away the airway is from the mouth, harder it is for the phlegm to be lost. So in this case, we are dealing with upper lobe bronchiectasis. So the answer is actually central bronchiectasis because this is classically ABPA ka presentation. Okay. Now, how do we reach at that diagnosis? So, central bronchiectasis per se is seen in number one, ABPA, number two, congenital tracheobronchomegaly, also known as Munier-Cohen syndrome, or as you suggested, cystic fibrosis. Now, this case scenario describes a patient with chronic respiratory symptoms, nasal polyps, digital clubbing, infertility, suggestive of Cartagena syndrome, which is characterized by situs inversus, chronic sinusitis, bronchiectasis, predominantly affecting the upper lobes. Now, Cartagena syndrome is a part of larger group of diseases referred to as primary ciliary dyskinesia. So, symptoms are due to defective ciliary movement. Bronchiectasis usually occurs in the lower lobes in patients of Cartagena syndrome, but the patients of cystic fibrosis, they have predominantly upper lobe symptoms, but here the presentation is of Cartagena. So the most likely here is central bronchiectasis of ABPA, which also predominantly affects the upper lobes. Now, ABPA is a debilitating lung disease associated with asthma and cystic fibrosis and can also be seen in Cartagena syndrome, characterized by presence of asthma, pulmonary infiltrates, peripheral blood eosinophilia, immediate type 1 skin reactivity, and serum precipitin antibodies to Aspergillus fumigatus, elevated total IgE, increased levels of Aspergillus specific IgE and G, and yes, central bronchiectasis. So, given the history, which is suggestive of either Cartagena syndrome or cystic fibrosis and upper lobe lesions in the chest, this is either ABPA or it is cystic fibrosis or it is ABPA with Cartagena syndrome. So the crux of the matter is the upper lobe involvement bilaterally. It is seen in cystic fibrosis and aspergillosis. So this question can be twisted in any manner, provided that you understand the crux of this. So there is ciliary dyskinesia. There can be lower lobe lesions suggestive of some disease process which is native to it. It is Cartagena, it can be upper lobe, specifically seen in cystic fibrosis, and the kind of bronchiectasis we get is a central bronchiectasis.